Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. In this episode, we'll be hearing a discussion about practical strategies to incorporate PTSD and trauma screening, diagnosis, and treatment into the care of people living with HIV. For this episode, I'm joined by Dr. Kathleen Page and Dr. Glenn Treisman, both from Johns Hopkins. For more information about this program and to follow along with the accompanying slides, please visit the links in the show notes. And to get access to all of our new infectious disease podcast episodes, subscribe to the CCO Infectious Disease podcast channel on Apple Podcasts, Google Podcasts, or on Spotify. Now let's get started and hear from Dr. Treisman.
I thought I'd start out by talking just for a minute about what we mean by substance abuse. And one of the questions we have is, what do we mean by addiction? And it's important to start there because people have a lot of confusion about the term addiction. It's the term patients tend to use. So, Kathleen, tell me how you think about addiction. When you think of defining it, is it a medical problem? Is it a behavioral problem? Is it a psychological problem? How do you think about it?
Yeah, well, first of all, thank you, Glenn, for having me. And it's really wonderful to be here with you, one of my esteemed colleagues as well. So, I really think of it's a combination of all of the above. It starts often with a behavior and a combination, sometimes psychological, sometimes people are having psychological problems and are self-medicating with substances, or sometimes it's just a behavior that people start doing and they like. But over time, people become addicted. And by addicted, I mean that they continue doing something that is harmful to them, despite the fact that they no longer enjoy doing what they're doing, or maybe they do for a moment, but for the most part, they're seeing harm in their life, and they're now no longer able to stop. And of course, we know that at that point, it does become a chronic medical issue that needs to be addressed from all aspects, right? From the psychological aspect, from the behavioral aspect, as well as with medications when needed.
So I've used this definition, a behavioral pattern of continuing use despite increasing consequences that ultimately disorders all functions over time. And the reason I like that definition is it does just what you said. It pulls together all the elements of this. Most people who become addicted to drugs don't set out to be addicted. They set out to get intoxicated or to have a good time or to join in or to make themselves feel better at a time when they feel bad. But the drugs over time seem to hijack the parts of your brain that involve volition, drive, and reward. And the use tends to derail people. I'm going to talk about a case that actually you have seen with me over the years. It's a fellow who I first saw in his early 30s, was a daily heroin user, frequent cocaine and alcohol user, who was always pleasant to us in the clinic, always smiling, always a nice guy, but always uninterested in any kind of treatment. Eventually, we got him to take HIV medications, but that's all. And then, quite a number of years ago now, he came in wearing a new set of clothing and had converted to being Muslim. And at that point, something had happened that made him decide to try to clean up his life. And although he was not eating pork, he was still using heroin. And we were able to use his conversion as a place to start a conversation about giving up drugs. Subsequently, he lost a tremendous amount of weight. He was 180-ish, his weight dropped down to about 135, and he had abdominal swelling, felt fatigued, exhausted, and had tremendous malaise. So that would be a kind of a typical patient for us to see in our clinic. He turned out to have a 1 centimeter hepatic cancer that we were able to treat. So that kind of case is the kind of case we see a lot of. Tell me a little bit about how you start with a patient when they come in and they're using.
Yeah, so I think that case, highlights so many different issues. The first is that, he, as you mentioned at the beginning, he wasn't very interested in getting treatment for or stopping his use of drugs. But then over time, perhaps because of his religious conversion, he felt more open to that. Now, this person, I'm speculating, but I suspect that if he was injecting drugs and then had a hepatoma, he probably had hepatitis C, possibly, that led to this complication. And this is where, I am very active and passionate about, is that intersection of substance use disorders, and infectious diseases. And so, Glenn, you probably remember a time not so long ago when there was almost, I wouldn't say a dogma, but sort of a sense that if someone was using, we wouldn't treat their hepatitis C, maybe we wouldn't even treat their HIV, and because it was a bit of a paternalistic sense that, if they're using, then they can't be taking their medications. And of course, we know now that, those two things don't necessarily go hand in hand. Many people are using and they're still able to take their medications. And really, it's our job as much as possible to make sure that people have access to the medications that are going to help them, whether it's for their HIV or Hep C, behavioral issues, and then really meet them where they are and help them make that transition to getting the best care they can. Recognizing that not everyone is going to want everything at the same time. And so we work with patients along with that.
Well, one of the things that the reason I wanted to start out with the definition is that because addiction has this volitional component, that is, if I can cure hepatitis C and I have a simple drug that doesn't have much side effects, most people will complete treatment. If I have a drug that cured schizophrenia, my patients would take it. They take neuroleptics which don't cure schizophrenia and have terrible side effects, and they still take them. But if you have heroin addiction and I give you a drug that blocks opiate receptors, most opiate addicts won't take it because they have a volitional component that's different. Nobody goes to a 12-step program and cures schizophrenia or HIV or hepatitis C, but people do get sober in 12-step programs. And so there is this behavioral/volitional element to these patients that makes many physicians blame the patient and feel like the patient is not cooperating because they don't want to get better. And I think that that's not a fair characterization. These drugs hijack the parts of your brain that have drive associated with them. So that's why I mentioned this guy as a useful example.
I think that's exactly right, and that's how we see it, right? So even in our own lives, maybe I'm not using drugs, but there's other behaviors that I have that I choose to have, and I may not be ready to give them up. Some of them are not as healthy as others, and that's part of being a human being. And I think our job is to meet people, as I said, where they are. Often, I do meet sometimes, especially when we're doing work out in community settings, where people, honestly, at that point, they really are sick and tired of using the drugs, and they haven't been able to access good medical care. So all they're doing is really treating their withdrawal most of the time. But that's one group of people. But there's other people who just really want harm reduction. They don't want to die of their addiction, but they're still wanting to use. And I think our job is, again, to mitigate risk and to help them move in the direction of health, but we can't force it on anyone.
So one element of this thing that you just mentioned is treating the physical withdrawal, which many patients have. But you do have to remember that many of our patients, in fact, most of our patients, at some time or another, have gone through withdrawal, been off, and gone back to using. And people miss the fact that people use to get high, to feel good. They use because the drugs produce a euphoria, and both animals and people will work to get the drug. In fact, our patients work incredibly hard. They work 365 days a year. They don't get weekends off. They don't get vacations. They are constantly trying to get enough drug to go to the next day. And so these drugs do make people work to get them. And we have to recognize that is not a pure choice. Mm-hmm. It's a driven choice.
That's exactly right. And I think people, when we talk about the work that they go through, it gets harder and harder, I think, and that leads to just other really risky life circumstances, right? So people will work so hard to get the drugs, whether it's because they want to avoid being sick and withdrawing, or because they want to get high, or a combination of both. And that's how people end up without a job, on the streets, perhaps having survival sex, all sorts of really difficult circumstances that just compound the problem.
Right. And our population of patients with HIV are notorious for having very high rates of use of any kind of intoxicating drug, not just addictive drugs like opiates, but hallucinogens and inhalants and other non-medical psychotherapeutic drugs, so that we have very high rates of use of drugs. And I think that gets to the fact that this is a vulnerable population.
Mm-hmm.
That is, people get HIV because they're vulnerable, and people get addicted because they're vulnerable. And we've talked in previous presentations at Clinical Care Options about depression as a vulnerability and personality as a vulnerability and life difficulties as a vulnerability. So talk to me a little bit about how you approach a patient, understanding their vulnerabilities to get them started.
Yeah, for me, I think one of the most important things in my patient care is really establishing trust and rapport. I mean, it's really hard to be able to help someone if the person in front of you doesn't trust you or doesn't feel like you care about them, or you're just looking at the computer or whatever. So I really honestly often start with very open-ended questions to have people tell me about themselves, how they got to where they are, why they are here in front of me, and what their goals are. Because it really helps me then frame the rest of the conversation. If someone tells me my goal is to, I'm 100% committed to stopping the use of fentanyl, that's one thing, whereas many other people will say, my goal right now is I just don't want to feel that sick. And for example, I want to get my HIV treated or whatever. And so starting with what the patient's priorities are is number one. And then the understanding of what their life circumstances are, not just now, but sort of that trajectory is important because, as you said at the beginning, addiction is complicated because it's not just about if it were just like a virus, you can just treat it and that's it. It would be easier, but there's all these things, behaviors, life circumstances that really impact that, and without that understanding, it's really hard to really, as I said, meet the patient where they are.
So one of the things that I've done a lot of in my career, and I know you've done a lot of, is trying to help other people understand addictions. It's a disease, it's a disorder, and not a moral issue, that these drugs hijack decision making, that the behaviors that people show that where they seem uncooperative are usually a symptom of the disease and the condition, and that we kind of know what to do. You mentioned the fact that people with addictions need the same medical care as people with diabetes and heart disease and HIV and hepatitis C. And the desire not to treat people comes in with many excuses, but quite honestly, patients with addictions are harder to treat. They're more complicated and they're more difficult. Patients with psychiatric disorders are more difficult. How do you deal with the kind of increased level of complexity and time neediness of our patients in your work? How do you keep going?
Well, so in terms of personally how I keep going is because, on the one hand, you're right. They are complex, and they're complex not just medically, but in a sort of social, psychological. There's a lot of complexity, some of it which seems beyond my control. For example, when people are unhoused and that may be driving a lot of their behavior, it's hard for people to get well if they're surrounded by other people who are using drugs. So some of these things seem a little bit out of my control, but at the same time, you and I have both seen people get better. And when they get better, it's really amazing, right? You can see the transformation, not just for themselves and their own health, but also for their families and their loved ones. So it's really the impact, it goes, ripples through. I do think that, when we think about patients who have complexity because of their substance use, we should think the way that we think about any complex medical illness, right? So when we think of a patient who has complexity because of whatever, cancer care, et cetera, elderly age, et cetera, we try to provide more wraparound services. That's what we do. When we have a complex patient in the hospital with whatever, we don't say, okay, well, that person needs less care because they have renal disease, cardiac disease, and cancer, too complex. We're going to give them less care. That's not what we do for those patients. And the same way, we shouldn't do that for patients with addictions or substance use disorder. We really, I think, the key is to invest heavily in more care. So we give more care, more wraparound services. We rely a lot on us, on you, like have these sort of clinics where we have embedded psychiatrists and therapists and navigators and community health workers who can go out to the community and really engage people, case management, all of those pieces are really essential. And so I guess my answer is I don't see it any different than any other challenging clinical case. But unfortunately, sometimes the resources are not there. And hopefully, I think attitudes are changing. But I would argue we need to think of this complexity the same way as we think of any other medical complexity.
So we talk about the core elements of addiction, and we talk about role induction, detoxifying people, rehabilitating them, treating their morbid psychiatric conditions, and relapse prevention as a set of crude steps. But the most important one is the first one, persuading the person that this is a disorder that needs treatment. And like the vast majority of people, many of our patients are convinced that this is a moral failing, that they're a drug addict, and that therefore they're in the discard pile, and they can't do anything about it and feel quite helpless. I have used both confrontation with a smile, where I try to get people to see the devastation their drug addiction is producing, but also motivational interviewing, where I talk to them about their life. What do you say to patients in the first round of talking to them about their addiction?
I often ask them, well, what do you like about it? What is it that brings you pleasure, and what is it that you like? And then from there move, what is it that you don't like so much? And that I think just having patients verbalize that and maybe reflect. I mean, they probably have know what they don't like, but they maybe haven't said that. And so that sort of helps us open a little bit the conversation. Okay, weigh the like versus the not like. Then from there, move more towards, so if you were going to change some of the things that you don't like, how do you think you could do it? Based on, again, their circumstances. So some things may be more feasible than others. And I think that approach helps, again, people reflect and think through it. But I also agree with you that for so many, I think a lot of the patients feel surprised when we talk about this as something that is treatable, that is not a moral failing. They've been hearing about it from everyone else, from society. And so it's very internalized, that sort of feeling and stigma that this is their own failing, and and so I think working through that is also super important, so that they can see light at the end of the tunnel. It's hard to get out of this if you're hopeless.
So we detoxify many people from opiates as an outpatient, where we slowly taper them off, give them substituted things. I will give people other opiates that are safer and less likely to cause a fatal overdose if people are very committed. But ideally, I like to bring people in the hospital and get them detoxified. You work in a much more community setting than I do, and don't really have the Hopkins ER and Meyer 6 to slip people into. What do you do about detoxifying people from opiates when they're ready?
Yeah, so I guess for the audience, among the things I do, we have a mobile clinic that sort of goes to different corners of Baltimore where there's high overdose rates, and we try to provide integrated low threshold buprenorphine treatment for those who want and need it, as well as integrated infectious disease treatment. So HIV care and STI and hepatitis C treatment, wound care, etc. The answer to this question is the same as it was 5 years ago, but it's gotten a little bit more complicated. I would say that when we first started, and this clinic is called The Spot, while fentanyl wasn't out in the streets, it wasn't as prevalent. And I think starting people on buprenorphine as an outpatient felt easier in the sense that what people experience really seemed to follow more the rule books of what we all have read about. So if people waited until they had some signs of withdrawal and they started using the buprenorphine at a lower dose, and then sort of go up until they got to their needed dosage, it seemed to work. And I just had a lot of patients, and I'm talking about like 5 years ago, who would come back and said that was like miraculous. I hadn't felt well in a really long time, and then I did what you told me, and I feel so much better. I'm sort of sad to say, and I think that maybe the experience of others on the call who are living in this fentanyl era, that it's not as easy. We still get people on buprenorphine and can help them. But I think because fentanyl is so potent, because it's there's, I guess it has a short half-life, but it stays in lipids and fat for a long time. We are seeing much more difficulty. Patients are telling us that things are not working as well as they were before. So we have to go higher doses, and often even at the highest doses that we prescribe, which is 36 milligrams in a mobile setting, it's really not enough. And so we end up having to transition people to either inpatient detox or methadone clinics. So this is to say that's not to discourage people from doing low threshold buprenorphine. It's so important. We need more access. There's too many people out there who want to be on buprenorphine, and they're having to buy it off the streets because they can't, get a physician or a provider to prescribe it. So we need to do more of it. But I also am cognizant that it's gotten more complicated, and that
it's much tougher.
It's the first step.
When I started, the average person in Baltimore was on between 10 and 15 milligrams of oxycodone equivalent in heroin a day when they were using heroin. Some people at 40, but those kind of numbers. And now many of the patients using fentanyl are on 50 to 100 or even higher equivalent milligrams of oxycodone. So it's very, very high morphine equivalents that our patients are using. And therefore, when you give them buprenorphine, you precipitate withdrawal because of the blocking effect of the drug. It is very protective of overdose, though.
It is fantastic. I mean, the data on survival benefit is huge. And so what I tell patients, and a lot of the patients that I see out on the street, they're not even looking to quit completely. They just want to reduce the risk of death and sort of harm mitigate. And so if I can get someone on buprenorphine, I tell them, just take it. Even if you're going to be using other things, just have buprenorphine in your system so that at least it provides some level of protection from overdose. And that, I think the hardest piece is, though, as you mentioned, getting them on it. Once they're on it, they can still, they can keep on taking even if they're using other drugs, but getting them on it without them feeling terrible and feeling like they may, either we're precipitating withdrawal or it just feels like that's what's happening is tough.
Yeah, we've been mostly talking about opiates. I do want to, we do also have to think about stimulants and diazepines and alcohol and other things. We have an epidemic coming into Baltimore now of xylazine use along with opiates and horrendous skin injuries because of it. When we talk about giving pharmacological treatment of opiates, though, often getting people off includes getting them to the hospital and putting them on other things that will mitigate some of the withdrawal. It's very hard to do that as an outpatient because those drugs can make people faint and can, if they're not hydrated well, giving them things like clonidine or methocarbamol can be really problematic. So when we have these tough patients, we're really stuck bringing them in a lot of the time. We know that treating people decreases the medical comorbidities, prevents HIV transmission, prevents hepatitis C transmission, improves political and social determinants of health in terms of what people will get once they're sober. They get much more access to resources and do much better. What do you think the biggest barriers are for our clinician colleagues in terms of getting people in? Starting them out?
Yeah, I think so. I guess barriers for our colleagues are some of it is familiarity with treatment of addiction and sort of, I think that's still part of it. I think the younger generation is getting more intentional training in substance use disorder. So I think hopefully that's going to get better. So part of it is that, there used to be all these barriers to prescribe buprenorphine, you needed an X waiver and all these things that are gone. I still, unfortunately, think there is stigma, provider stigma, and that needs to be worked on. And then I think the other piece is that it's what we were talking about before. People with substance use disorder coming, in a traditional clinic, people have to come to the clinic, and often they have to make appointments, and they have to, these are pretty, you have to be pretty organized to make an appointment at our clinic, except for yours, Glenn, where people can walk up, which is great.
So that is a thing. We have 1 day a week. It's my clinic day where anybody who's been seen can roll in and be seen. We try to keep everybody else on track so that people can come get their care and leave and not have to sit around waiting. But on my clinic day, we will take anybody we've ever seen. Sometimes that results in a very chaotic clinic. But it is a very important part of planning treatment. That is, resources for people who are not organized enough yet to get it the way we usually like it to be gotten.
Yeah. And I think we see the same when we go out on the van, right? It allows people to, come in. It's a little chaotic, but they don't have to schedule an appointment way ahead of time. For those people who are not in that place of being able to be organized in that way. And the other thing is that it allows us to do frequent visits, which I know you do as well. So it's really hard to do this and, see a patient and then say, come back in 3 months. You really need to be seeing them every week and establishing rapport and making sure that, whether you see the progress or they're taking a step back, just that consistency of us as provider being there, they know that they can see us. I think that's huge. And unfortunately, honestly, for most providers, they don't have that choice. The system is not designed either to be friendly to providers who want to do that, or for patients who, to be able to meet and have their visits in that way.
Right. And I think that one of the biggest barriers for our colleagues is time and infrastructure. That is, there isn't enough time for patients who need extra time. There isn't any help with difficult patients, easy pathways to admission for detoxification or for rehabilitative treatment. And the other thing is that most doctors are introverts. We notice our failures and we don't notice our success. Doctors tend to see patients who are coming back relapsing over and over again and not notice the fact that a bunch of the patients that they've seen don't come back anymore because they're doing great. We see them every 3 months. We see them every 6 months. They don't need much from us. And we tend to not notice that they were the people who were needy 2 years ago. And I think that produces a lot of pessimism about treating substance use disorders. In our clinic, in a 5-year study, we find that we get about 35% of people indefinitely sober. It all covers. That's a huge outcome. And people say, well, it's only 35%. If I could cure 35% of pancreatic cancer, I would get the Nobel Prize tomorrow. And so we don't tend to think about this as a chronic illness that when we succeed with it, we've done something really wonderful. The great thing that both you and I have is we are senior people and we've seen the miracles. And I think it encourages us. I think our junior colleagues who don't have enough opportunity to see the benefit patients reap over time tends to make them pessimistic and not make them willing to fight to get the resources for their cases.
Yeah. No, I agree. I mean, honestly, it's one of the most gratifying and wonderful things to see a patient recover from addiction, because then you get to meet them and see them the way they really are. And you can see, and it's even more evident how this disease hijacked their brain. But if all you see is a hijacked brain, it's hard to imagine them when they're well.
So one of the things that you and I share is this idea of integrated treatment. That is, your van doesn't just say we're here to treat heroin addiction, or we're just here to treat HIV, or we're just here to treat hepatitis C, or we're just here to check your blood pressure. We are here to get you better. And I started my program in the HIV clinic in 1988 with the idea of integrated care. You would get your psychiatric care, your substance abuse care, and your medical care all in the same place, all under one roof. And I think that that's a very important model that people tend to miss. And if you're a primary care provider for HIV patients, if you don't have that, you have to develop a virtual version of it, which you have. When you were interested in our patients, you came and saw cases with me, so you could be more effective. And we've had many, many people come and spend time with us in the clinic, try to get a sense of how to approach these things. Integrated care is, I think, the balm for this issue. Well, any final things that you want to make sure the audience gets that I left out?
No, I think you covered so much. The thing I will say, just to reiterate, integrated care is really good for patients, and it's really good for us as providers, because then you're part of a team. You're not feeling so alone doing things, and it's just more fun for everyone. So hopefully the audience can and nowadays you can build virtual teams that can help along. What I would just say is for people who are listening, not to be afraid of substance use disorder. It is one of the most gratifying illnesses to treat, and it's really I think a privilege that we all, if you're taking care of patients with HIV, you probably already have a soft spot for people who are a little bit underserved and maybe vulnerable. And this is just part of what we see, and it's our duty to take care of the whole person, not just one thing or the other.
Well, I want to thank everybody who's helped make this program possible and Clinical Care Options for sponsoring this. Again, I want to remind you that that's Dr. Kathleen Page at Johns Hopkins, and she's a professor here, and you can get in touch with her, and she's glad to help, and I'm glad to help. And we really appreciate Clinical Care Options supporting this, I think, very important part of care for HIV patients.
Thank you very much to Dr. Page and Dr. Treisman, and thank you to our listeners for joining in. To view the full program on making healthcare an integral part of HIV care, click on the links in the show notes for this episode. Thank you and have a great day.